Welcome to BW Healthcare World. As a part of the podcast series jointly being organized with Kaho, we are going to be talking about the cost of poor quality today. My name is Harbinder Narula, and my guest for this particular topic is Professor Anupam Sibal, who is the Group Medical Director and Apollo Hospitals Group since 2005. Professor Sibal, thank you so much for joining us. For this particular conversation regarding the cost of poor quality. But before we move into or delve into this conversation, what do you exactly mean by the cost of poor quality? And is there a way to measure it?
Uh, Thank you so much, Harbinder, for this opportunity. Delighted to be a part of this conversation. When it comes to, say, manufacturing or you're looking at a product, it's relatively easy. There is a cost. It could be something to do with manufacturing. There was an error, something that happened post-production, something that happened in packing, or something that happened during, transfer, or something happened when you bought it, wherever you bought it, or whether it's in a showroom or whatever. But when it comes to sort of healthcare, it's a little more complicated. So there isn't a precise definition, but anything that has happened that we didn't expect should have happened really is the way I would look at. So, all of us, when we go into a hospital, be it as patients or when any of our family members or friends or colleagues is admitted, or for that matter, has any health encounter, whether it's in an outpatient setting or as an inpatient, what we expect is that the patient goes in, he has this particular complaint, the complaint gets resolved, it happens in the shortest period of time, and it happens without any complications, and the results that we get are sort of long term as would be expected. So that's really what we expect, and anything that goes outside that would be something that would be classified as poor quality. Of course, we also have to be cognizant of the fact that I think the perception about quality needs to be a little realistic when we talk about healthcare. See, there is virtually no procedure that has 100% success. Something can go wrong. The way you react to paracetamol might be very different to the way I react to paracetamol. We can go in for a dental extraction. Someone will develop a little more swelling, someone will develop bleeding, someone will develop an infection. The same dentist following the same technique. It is because each one of the 8 billion people that exist on this earth have their own unique genetic identity. We are just about understanding the concept of personalized medicine. And therefore, how our body reacts is going to be very different for any two individuals. And therefore, when we look at the comorbidities, we look at the risk factors, if we look at it from a holistic point of view, realize that, listen, there is no such thing as 100% success. And if you look at the best published outcomes, you look at best published outcomes after a bypass. So highest is like Cleveland Clinic, which is 99.4%. We benchmark at Apollo with them and measure outcomes in all our units. But it's still 99.4. It's not 100%. And if you look at any other intervention post neurosurgery, or if someone has a stroke and you're giving a medication to dissolve the clot, there is a risk of something else happening. So we really do need to educate the public at large, saying that there is no such thing as 100%. There are complications well known with virtually every procedure, every drug. What we have to make sure is that if it's something, even if it's like 5% or 2% or 1%, and it fits within that, that is not poor quality. That is still within what is expected. But poor quality is if you experience delays, if you get an infection which you shouldn't have in a clean procedure, or your length of stay, which was say expected to be 3 days, becomes 6, or you've had a procedure and then you need to go back into the OR, or if you've been on a ventilator and you were taken off the ventilator and you go back onto a ventilator, or if you're on a ventilator and did not have a pneumonia, you develop a pneumonia. So these are all what would be classified as poor quality.
And Dr. Sibal, all of this impacts the patient satisfaction or at least the perception that they create in their mind about the facility. Now, how does this poor quality create the satisfaction levels which can be challenging for the hospital in the long run? And how does this also translate to financial loss, both when it comes to the loss of patients in the future or the loss of reputation for the hospital?
And I think very important questions that you've raised there, very critical for anyone to realize that, we want a patient to be satisfied. And that satisfaction starts off with the way you sort of introduce what is going to be done to the patient. And in our case, also the family members, because family is critical in India, play a very, very important role in the decision making and also the experience and word of mouth after the procedure. So it's extremely important that we get this right. If someone is dissatisfied, then they will tell others about it, and the reputation that every organization tends to painfully build over years or decades can get tarnished. And in today's world, it's very easy for that to happen because of the power of social media. One tweet, one message on Insta, one WhatsApp group then starts to circulate, and it can be damaging. So every organization tries its very best to make sure that the experience is good, the quality that we deliver is very high quality, and the patient is satisfied. Now, the economic loss happens on multiple fronts. Firstly, if a bed is blocked and that bed could have been used for a procedure, then there's a loss there. There is a loss in terms of loss to the community as such. If someone stays in, they're unable to go back to doing what they do productively. So there's a loss there. There is an additional cost in terms of medication that is used or consumables that might be used. So that's a loss. That's a loss to the community. Might not be directly a loss to the hospital in this case. Then, of course, if it goes into dispute, it goes into litigation, or when it comes to a dispute, there might be actually a conflict in terms of payment due, and sometimes a payment cannot be made. So there's an economic loss there. And then, of course, the most important one is if it goes to litigation and you get sued, and then there is an adverse judgment, and then there is a compensation that has to go. Now, this, as you know, in the United States is really very, very significant, and litigation rates are increasing. What we are also seeing in India is that we are seeing more litigation than we used to in the past. And that is really a factor of growing awareness. People are aware of their rights. People also question. And as a result of that, we are seeing increased litigation. Nowhere near what it is in the US, but definitely rising. And litigation costs can, of course, be very, very significant. So on multiple fronts, there can be economic loss that can ensue.
This is very interesting because, I was talking in the recent conference that we did on how a patient over a period of time has become a customer. And the relationship between the care provider and the care receiver has kind of changed over the last few decades. But when we are looking at the quality of care or when we are looking at the cost of poor quality, it is not just for external customers, it is not just for the patients. It also, in my opinion, creates an impact on the internal customers, which is your employees. How does the poor quality, in your opinion, impact the productivity and the morale of the people who are working with you in the hospital, sir?
It has an important sort of, what should I say, effect on people who are working at multiple levels. So first of all, we have to realize that why do people join healthcare? You know, there are like 3,500 career options in class 12. Why would somebody choose medicine? It's hard, it minimum of 9 years, most people 12 to 13 years of training, um, grueling hours, very poor quality of life in terms of work-life balance, weekends, and so on and so forth. Why would someone choose nursing? I mean, you could join software, you could finish your training in half the time. Nurses have to have, huge amounts of training. And then as a practicing nurse, life is hard. You have to do night duties, you have to be with patients all the time, you have to meet every little need that they have. Very, very taxing. Anyone in healthcare, be a technician, be a dietitian, anyone who chooses medicine chooses because it's a calling. They do this because they genuinely believe they want to make a difference. They want to take someone's pain away. They want to bring back a smile on someone in distress. They want to take someone's worry away. That is the intent why people join medicine. So you have a surgeon and a procedure happens and there's a complication. So um, unpredictable complication or something that was not expected, it pulls the surgeon down, it pulls the entire surgical team down, it pulls the medical team down. The nurses involved in the care, nurses involved in the OT, the technicians, everyone. So, it demoralizes you, like you rightly said, when something goes wrong. So, poor quality, demoralization, point number one. Point number two, that quite often, there is the concept of the second victim. So, one is the person who suffered, and the second is the caregiving team. They also suffer. Some of them internalize it, some of them vocalize it, some of them really struggle. And clearly, we've seen that, and there's enough data globally on this of the emotional loss that happens with anything untoward that happens in healthcare. It really has very serious impact on people who were involved in care, and when people who are involved in care get impacted, then those, their friends, their co-workers also tend to get, affected by what has happened. So clearly there is not just about the external bit, but like you rightly said, internally also there is a huge, huge loss in terms of how the team functions after something that would be classified as poor quality happening in the organization.
And Dr. Sibal, I'd like to bring the attention towards, something that we call the hospital-acquired infections. Now, this is also becoming a very important area of concern. How do you think the hospital-acquired infections affect the overall cost structure in the hospital setting?
Huge impact. And see, we have to realize that every hospital, though everybody tries their best to control hospital-acquired infections, not everyone has protocols that they keep revising. And the reason for that is that, you need to make a huge investment in terms of not just the money, but also time. You have to motivate the team. You have to keep changing protocols as as newer evidence emerges. You might follow one particular step that you have to change because there is evidence that if you modified it, the risk of getting a hospital-acquired infection is lower. You might have to change the consumables as better consumables become available that lessen the risk of an infection, be it catheters, be it cannulas, and so on and so forth. So hospital-acquired infection is a very serious concern globally. We have a lot of data from the West, in terms of the impact a single urinary tract infection has or surgical site infection has. Of course, bloodstream infections are more serious, are more worrying because they can have an impact on the whole body. And then, of course, developing pneumonia when you're on a ventilator. These are the four areas of hospital-acquired infections. And if you look at accreditation systems, like, for example, Joint Commission or NABH, they lay a lot of emphasis on how is it that you can control, prevent, or learn from any hospital-acquired infection. And a lot of energy is devoted into standards and measurable elements on what does the organization do pan organization, what does it do unit wise, what does it do in high risk areas to prevent infection, how do you pick up infection early, how do you treat infection? Do you monitor what bugs are growing and what is it that you can do to decrease the chances of having resistance? Do you use bundles, for example, to decrease the risk of infection, whether it's urinary or bloodstream or ventilator associated? So, hospital-acquired infections are a very, very important part of, what would be classified as poor quality, because no one really should have, even though there are risk factors, even though some patients are more susceptible, every attempt must be made to bring down hospital-acquired infections to close to zero. And it's a multi-pronged strategy, requires a team approach, lots of commitment from the organization. But clearly, one of the top areas that organizations across the world are now focusing on what is it that can be done to minimize or to stop hospital-acquired infections.
Professor Sibal, apart from your being a practitioner, you're also having a very important role that you're playing at the hospital level, at the group level. And how do you deal with the failure to comply with patient safety protocols? For example, there could be a a surgery which has been done to the wrong side of the patient, or there's a diagnosis that is missed. At the end of the day, we are dealing with doctors who are also human beings. And in India, there are, it's not a very comfortable life for doctors in terms of the pressures that they are dealing with. So, how do you deal with such kind of, uh, failure to comply with patient safety?
So, like you rightly said, there are a whole lot of pressures that healthcare professionals constantly face. So, you have to have a system where you have more than one check, and that is very important. Gone are those days where there was one person checking. So, let me just walk you through safe surgery. And safe surgery is extremely important. You want the right procedure to be performed on the right patient. And you might say, well, how ridiculous is this? How can a particular procedure not intended for a particular individual happen, but it happens? I mean, very recently you heard about that in the US, and these incidents keep coming. So one is the identity of the patient. Then second is, any organ where there are two sides, you operate on the right side. So, you have to operate on the left side of the brain, but you open up the right side, you know, or any organ where, there is more than one organ. So you have to operate on the right kidney, you end up operating on the left kidney or the left ureter instead of the right ureter. So all of these things sound like, how can this ever happen? These are never events. They should be never events. They should never ever happen. So it starts with having a system. So if we talk about safe surgery, so it starts off with a safe check. It starts off with the patient being involved. Now, a patient knows my right knee hurts, not my left knee. So you ask the patient, you mark it in such a manner that at the time of the operation, you can see the marking. In addition to the patient, the treating team is involved, not somebody else who's not going to be there in the OT. Then you make sure that everything that you need in the OT is available. It shouldn't be like the surgeon is in the OT or the X-ray got left in the ward or the MRI or the CT is not available. It needs to be displayed. Then you have to go through a checklist where everything is checked. Okay, this is the name of the patient. How do you identify the patient? It has to be the name. Organizations can follow what they want, usually an ID. If there has to be a band, you sort of match that. Then you say, okay, this is the patient for this and this procedure. Okay, do we have a consent? Has the consent been signed by the patient? Has the consent been signed by a witness? Was the healthcare professional who took the consent? Was that person the right person to take the consent? Then you go in and say, okay, do I have all the equipment that I need? I mean, there's no point starting a surgery if, oh, that instrument is available in the other OT and you have to wait, right? And after that, then everybody pauses for a minute. The anesthetist or whoever's leading the process says, okay, um, this done. Then the operating surgeon or the endoscopist says, okay, time out. So you've checked everything multiple times. If you leave it to one person one time, he's suddenly on the phone, something happens, mistakes happen. So that is why, for many, many things, there is more than one set of eyes that must look at and document. When you have that in place, less the chances or close to never having a never event increase. And this is about identification of samples. Imagine you take a biopsy from a tumor and it gets mixed up. I mean, you can't really go in and take that biopsy again, or it gets stored it had to be stored in normal saline, but it gets stored in formalin. So because it wasn't stored in normal saline, you can't run particular types of tests. Or if it was meant to be stored in formalin, but it got stored in normal saline, it gets damaged. So for lots of these things, you have to have a system. So to prevent all these incidents, you have to have a very clear policy at the governance level. And that's why if you look at accreditation, the accreditation doesn't talk about the nurse, it doesn't talk about the doctor, it doesn't talk about the head of the department, it doesn't talk about the CEO. It starts with the governance. Okay, it starts with the board. How does the board look at quality? How does the board look at making sure that you have high quality? Right? How does it link with the mission and vision? And does the organization have the resources to be able to manage a quality program? Then it goes and clearly defines what is the role of the CEO, what is the role of the medical director, the nursing director, the quality head. Then it goes down to the level of the department. What is the role, responsibility in managing quality at the head of the department level. Then it goes down a step lower and a step lower, and then goes down to the junior most person on the floor. What is that person's responsibility? How often do you review your patient safety and quality improvement plan? It has to be done annually. Now, if, for example, a department feels that you need resource X or resource Y to be put in, what is the mechanism that it goes up to the level it should to be able to get that resource? What do you do in terms of training your staff? What is it that you do with the data that you collect? How do you make sure that the first of all that the data you collect is relevant to what you're dealing with? What is the benchmark? How do you actually analyze the data? What tools do you use? Does it go back to the department saying, okay, you had patient falls that were more than what would be expected? Why did it happen? What did we learn? Or you were having needle stick injuries for the nurses because the sample collection there was a problem, or the way they were disposing needles there was a problem. So do we complete the loop or not? If God forbid something serious happens, do you do a root cause assessment, a root cause analysis? Do you pass this back on? Do you get into a proactive mode and predict that this can go happen, and what is it that you can do to prevent that from happening? So do you do an FEMA? Do you have the drills that you should from the point of view of, God forbid, a fire, and sad incidents about fires keep getting reported. And what really helped us during COVID was the preparation in terms of an epidemic. So each hospital is supposed to have a clear plan that how will you handle a patient walking in into the emergency, into the outpatients? How will you control the spread of infection? How will the training be? Everything should be written, documented, tested. Very importantly, tested that it's contemporary to the relevance. We also live in an environment where there are threats. So what if there's an explosion somewhere, and how do you deal with that? And if suddenly you get 20 patients who've had injuries because of an explosion, how do you handle all that? So all that becomes a part of the larger way that you run the system.
But Professor Sibal, this brings me to my next question, that if you're dealing with a set of procedures and policies that you've already created, which are going to govern how the operations are going to be run in an hospital, but like I said earlier, you are dealing with human life, and the people who are dealing with the human life are also humans. Errors happen, right? Not everything goes the way we have planned every time. How do you deal with such errors? Because, do doctors or medical staff or the support staff report these errors? And how does institution look at this when the errors get reported, to create a
So
culture
there
that,
are
it's not a challenge anymore for them?
So there are two aspects to this. One is, what do you do as an organization to prevent or minimize the risk of infection? So for example, there are certain very complicated procedures for which you need very specialized training. So for example, not every cardiologist can do the most sort of implant the most complicated of pacemakers, or an adult cardiothoracic surgeon should not be doing open heart surgery in a newborn baby. So what is your system? How do you credential? How do you privilege? How do you look at performance on a regular basis annually? How do you do re-credentialing every 3 years, re-privileging, new procedures become available, and so on and so forth. So that is one aspect in how do you prevent that. Now, your question is, you might have the systems, but of course, human beings can sort of make mistakes. So firstly, you have to realize, why did the mistake happen? And usually it is not, I mean, in most cases, the vast majority, it is not because of one person's mistake. It is usually a series of things that went wrong, and multiple people actually failed. So it's a system failure, not an individual failure. Of course, sometimes you can have a situation where someone does something that they shouldn't have, but those are not so common. In fact, they're rare. What you usually have is like maybe two or three people did not do what they should have done, as a result of which there is an outcome that you see. Now, how do you actually get to know that it's happening? You have to have a reporting system, which means you have to have a culture where people should feel, it's okay to report. So we ran this exercise several years ago where we actually started encouraging people to report. So, you normally get like sort of a recognition or sort, and we would have wow cards and employee of the month. It's usually, oh, you did something wonderful. We also started the system that you give a wow card if you reported more things that shouldn't have happened that happened. For example, a 5 minute delay in giving a medicine, or the way the temperature was taken, or there was some other issue, and you actually reported that. So this suggested that your culture is open. You allow people to raise their hand and not fear that some action would happen because they reported something that is going to make the organization better. So this is where you build in that culture where people are able to speak freely. They're not worried about speaking, and you have to have a system where all of this stuff gets reported, it's analyzed, and then you circle back. Now you might have situations where a problem happens, and that problem happens again with that person. So then, is there a problem with that person? Is that person not understanding what the issue is and that you need to do more counseling? Or is there an issue with that the same complication has happened? Is there a skill set issue that that person needs some help with skilling? Is there a need to handhold that person? Is there some need for mentoring? So, you have to look at outcomes, you have to analyze them, and based on that, you will make 10 decisions and saying, hey, listen, I need to get someone more experienced to handhold this person for the next 5 or 10 procedures because we are seeing a trend. So, it has to be looked at holistically with an open mind, with a culture that encourages people to speak up.
And Professor Sibal, healthcare today has been changing more frequently than ever before. We are seeing technology advancements happening, new medical procedures coming up, new therapies being released, new equipment being, incorporated in the hospital. And there's a need for people to educate themselves, undergo training. What is the role of staff training, continuing education, and empowerment play in improving the care quality and reducing the associated costs? Uh, does more training lead to lower costs in the long run? And what is the view that Apollo has? What is your view on how you deal with this
So
situation?
it's very, very important to realize that while you might spend an X amount of money in terms of making your institution safer and focusing on quality improvement, you will save a lot in the medium term and the long term. One litigation, one something going wrong, and very importantly, we have to realize that we have to always remember that life is priceless and that you're dealing with human life. So whatever it takes to prevent any harm to any individual. Training is critical, and training again touches on many aspects. So training about something that's new, a new piece of equipment comes in, or a new way of doing the same procedure, or a new procedure itself is introduced. So there's training related to that. Then there's training related to what the evidence is showing. Okay, evidence said that this is what you should have been doing, say 2 years ago. Now the evidence says that this treatment works better, so you need to tweak your protocol. Then there is training about protocols that exist on the ground, on the floor, and orientation and reorientation and revision. And then, of course, you have to have training about compliance, whether it's drill, life support, what to do in an epidemic, what happens if there is, say, an argument in the hospital, or there's some violence that happens, what do you do? So all of these, pathways, protocols need to be revisited, and training needs to be done repeatedly. So training is critical, and every organization that believes in quality improvement and patient safety has a set of training programs that every single individual must go through every month, every quarter, every 6 months, every year. And this gets documented in their file, and human resource department is responsible along with the head of the department in making sure that we have compliance.
And what is the role of artificial intelligence and machine learning in predicting and preventing adverse events, thereby reducing the cost of poor quality that could be there?
You see, AI, as we can all see, is now all pervasive, and is touching every aspect of our interactions on a day-to-day basis. So when we look at using AI in terms of clinical care, we have to realize that there are tremendous opportunities for us to use and look at big data and see how the trend is. Say, for example, and we have Code Orange in our organization, where Code blue is when someone actually has a cardiorespiratory arrest and you have to revive them, and there's a protocol. But there's also code orange where you see that before someone has an arrest, there's something that happens. Usually, your heart rate will go down, your breathing rate will go down, your saturation will fall, and there is a window where you can intervene before things suddenly go down. So we have a protocol called code orange in how you intervene. So that's where AI and ML comes in. You have something with continuous monitoring that's telling you, like, these are the points to watch out for, and you get an alarm or an alert. And we see that with cars, don't we? That, this is what is happening with your gas, you need to do this, or this is what is happening with your light, or you need servicing, and so on and so forth. So, similarly, using AI to be able to intervene early so that you can prevent deterioration and, not have to intervene when the crisis develops. And I think AI has a role in helping us becoming more proactive than reactive. Quite often, we are reactive in medicine, and we need to use technology to be more proactive, and that in itself will improve quality, will prevent digression from what would be acceptable quality, and that itself will improve outcomes, and of course would prevent wasteful expenses.
And Professor Sibal, one of the things that I've observed when I look at the healthcare industry is everything begins with communication, where what are the symptoms that are reported and what is the interpretation of what is being said. What is the cost of communication failure, uh, whether between staff members or between the patient and the care provider? And how does it increase the poor quality and the associated costs for an institution at a macro level?
So communication is critical because there's just so much information that gets handed over from one team member to another, and this happens so many times during the course of a day. And so communication is critical. And again, accreditation systems lay a lot of emphasis on communication, communicating correctly. For example, you get a call from the lab and says the potassium is so and so. Now, there is a way to write down that potassium. And you have a read back saying, okay, patient this, potassium 7. And the lab person says potassium 7. And this person says, okay. And you made a note. Because you can make an error, no? If you hear 7 as 4.7, makes a huge difference. So communication at every step, from listening on the phone, writing stuff, handing it over. So, the handovers between a doctor to a nurse, nurse to a nurse, doctor to a doctor has to be standardized. Listen, are you covering all these things or not? Then when to pass on information. See, nurses are there on the floor all the time, the doctor's not, but doctor might be on another floor. So when does a nurse actually pick up the phone, or we don't use pages anymore, but call the doctor on the cell phone and say, listen, I have a problem, come up, this is what you need to do. And then that doctor has to communicate with the senior doctor. And if it means waking up the senior doctor at 3 o'clock in the morning, then so be it. But the communication has to be very clearly defined, the protocol. If you get the communication right, the chances of a mistake happening are fewer. But for communication to be right, there has to be a culture where people are allowed to speak. See, quite often nurses in our system tend to be, a little wary of talking to doctors. And the more senior the doctor, less the chances of the nurse speaking up. So we have over the years encouraged a system wherein the nurses speak up. They speak up to their seniors, they speak up to doctors, and they point out things to doctors. And you have an open channel of communication. Communication is critical. It is very, very important to get communication right. And if you get communication right, then you minimize the chances of something going wrong.
And Professor Sibal, this is very interesting. I mean, if I'm correct in my understanding, one of the reports in the healthcare industry that was floating until about a year ago was saying that a typical environment in India is where a doctor spends about 2 minutes with a patient. And rightfully so, because some of the doctors who people reach out to, they are very, very busy. Now, at the same time, the hospital is looking at more and more patients, and we are also looking at hiring more doctors. How do you, as an administrator's role, manage or balance between the quantity versus quality?
So, you see, we have to realize that it's not possible to see a patient or make a decision in 2 minutes. Now, this data that you see is sometimes from very, very busy government hospitals where, just patients just land up and, they end up, being seen very, very sort of quickly. I have to give full credit to our clinicians for picking up stuff because it's very hard. I, for example, cannot pick up things in 2 minutes. I need my time with the patient to take a history, to understand what's going on, examine. So there is a minimum amount of time that you need to spend with the patient if you are to look at a patient head to toe and you are to address the problem in its totality. And you can't really compromise in terms of time that you spend on a patient. Now there are ways on how your time can be better spent. For example, you don't need to measure the blood pressure yourself. Somebody else can do it. A machine can do it for you. You don't have to check the temperature. The weight and the height is done by someone else. So you don't have to spend time doing that. Certain basic questions that are not critical can be taken in. Okay, how many children do you have? How old is the older children? Was there any hospitalization? There are lots of other bits of information that might be relevant, but you don't have to spend time taking that. Somebody else can do that. And then you have access to that information which you analyze, you ask more relevant questions and do an examination and arrive at a diagnosis. So you cannot cut corners. You should not be cutting corners. Use technology as effectively as one can, and let others do things that you don't need to do yourself. But what you need to do yourself, you have to do yourself.
Professor Sibal, my last question to you before I let you go is, uh, and this is something which is, has been coming to my mind personally over the last couple of months. I'm trying to figure out that, when you're looking at quality, and you also mentioned when we started the conversation that there are things that go wrong, or there are things that go not as planned, and these are not intentional. But patients need to understand this. Now, this is a very tough conversation to have with the patients, especially in today's day and age. How does a hospital, or how should a hospital manage the perceptions about the quality that they are offering, while also setting the correct expectations in the minds of a care receiver?
So, there has to be a very clear policy in terms of communication that talks about patient rights, that talks about patient responsibility. So, for example, if you walk into any Apollo hospital, you get a sheet of paper which talks about rights, like, my right to second opinion. So we say, fine, you must take a second opinion if you want to, and we will organize a second opinion. Right to privacy, right to what needs or what can be shared with others and what can't be. But similarly, there's a set of responsibilities that we tell you how to get off the bed so that you don't have a fall because you might have had a medicine that's making you dizzy, or to use a call bell, or to seek help. So it goes hand in hand. Where you talk about responsibilities, you talk about duties. Then you also have to have a system where information is passed on in a very transparent manner. So, you are undergoing certain, procedures. What will each procedure entail? How much time will it take? What can I expect? What about pain? What are the possible complications? Do we have an alternative? Do we discuss alternatives to give patient the time, enough time to think about it? Then the procedure happens and the patient comes back and you explain what happened, what went well, or is there a matter of concern? It's all about constant communication. So when things go wrong, it should be like a surprise. It's like, okay, this is what happened, this is where we are, this is going very well, this is not going well. So it shouldn't be like a bolt from the blue. You have to have communication which is regular. It has to be structured. It has to be led by someone who has the experience, who has the knowledge, who has the expertise, very importantly has empathy. Because let's not forget, nobody comes into a hospital out of choice. Everybody avoids coming into a hospital as much as they can. And that is something that we as healthcare professionals should never forget. Whoever comes to us is in pain, either mental or physical, is worried, has so much going on in their mind. And we need to sit there very calmly, talk to them, hold their hand, and walk them through what we are doing in a manner that they are able to comprehend and understand. And sometimes you have to say the same things 5 times. And the patient might ask you the same questions 10 times in with one word here or there. So you have to have the patience there. And Dr. Reddy taught all of us this at Apollo, and he said, to every Apollo family member, in fact, we don't use the term employees or staff, we say Apollo family member, said, when you join the organization, and he would say this, when you treat a patient, please treat that person just like you would want your father, your mother, your sibling, your child, your wife, your niece to be treated. Don't do anything more, but don't do anything less.
Awesome. I think that is a beautiful message, and that underlying uh, empathy that has to be there gets demonstrated if you have this as a mindset while providing. Dr. Sibal, it has been such a beautiful conversation, and one thing which is very important for people to understand is that when we are looking at the quality of care, people, and this is from the perspective of the patient, they need to understand that it is in the interest of the institution to provide the best quality. It is in their interest to have you out of the hospital as soon as possible, because it is even more costlier to keep you in the hospital than to have you out. So
Absolutely.
that message, I'd like to express my gratitude for you to take out time to speak with us at BW Healthcare World. Thank you so much, sir.
Thank you so much, Abhinder. A pleasure. Thank you so much for the opportunity.